Hi, good afternoon from day 2 at Convergence. It's been a great session right now. I'm checking in from Summit, New Jersey at the Institute of Rheumatic and Autoimmune Disease. Um, I'm Eric Dein. It's great to be part of Room Now, chatting about more of the wonderful posters and abstracts here throughout Convergence. I'm going to talk about abstract 0563, where they looked at validating the Frax score in the US population-based study of patients with RA. We know that when you're thinking about your patients with rheumatoid arthritis or inflammatory arthritis, you always want to be thinking about fracture risk because we know that they're at increased risk. We know that the Frax score has an account in there that you can select that they have rheumatoid arthritis, and that elevates their risk in their Frax score, but that has not actually been validated in the past. So this is an epidemiology study, like so many of them. It comes from Olmsted County, Minnesota, and it is looking at patients with RA age 40 to 90 years old, and then there's a comparator arm without RA. And what they do is they use the calculator and calculate the expected number of fractures and compare to the actual fractures seen. So as we all know, if you've done the Frax calculation, which is very easy on the computer, you put in the age, sex, race, ethnicity, family history, BMI, RA, fracture history, smoking, steroids, alcohol, the secondary causes for osteoporosis, and it gives you the 10-year fracture risk. So in the cohort that they followed, the Frax had predicted a risk of major osteoporotic fractures of 67 fractures in the cohort over the 10 years. And they found 76, so just slightly elevated, and that incidence ratio was 1.1, which is not significant. When it comes to hip fractures, there's 21 observed fractures compared to predicted of 23. So again, very close to the predicted values. They then separated it by broken down by age and sex, and each of them had an incident ratio close to 1. So there was really no part where they found that the Frax score in actual observed fractures deviated from the expected amount from the formula. So I thought this was very encouraging. It shows us that the calculations that many of us have been using for the Frax score does have some validation when compared to real world data. And it's something that it's important to think about, calculate in your patients, and make sure that they're on therapies if needed to decrease their fracture risk. So great poster here and lots more from throughout day 2 of Convergence. Plenty more information coming. Check out Room Now for all of its great content. You can follow me at Eric Dein MD on Twitter, and I'll be checking in throughout the conference.